using it's called CAL, Computer Assisted Learning. Last time during my student time, we had to really sacrifice a lot of rats, guinea pigs, and mice to do all these kind of experiments. So slowly, they develop the system. So you really can simulate the situation so that your theoretical matter, you really can cooperate with the application. And this is a free website. It's from New Zealand. So you can really remember, or maybe I can share you the URL. So at any free time, you really can always practice this, and it's going to improve your understanding. (111). 10 minutes later already. Aduh. Where is the group rep? I want to see you. Can you on your camera? Hello.
Can you on your camera?
Batch rep, you open your camera. I want to see you.
Oh.
Oh, I know. You are my previous mentee, right?
I'm with Prof. Hamdan.
Last time you were with me?
No, but I met you sometimes.
Okay, so you are my familiar face. I could ask, I think all the students, they know me because there was no direct interaction. So all students, they know me?
I think majority, because you're conducting the, what do we call the orientation?
But that time, I think all students didn't arrive. A few students, they joined after that, especially the international students. So I really miss my opportunity to be introduced with all of you. So still I'm seeing 111 group rep. What is your comments on this? It's almost 8 to 10 minutes delay.
Usually, previously during the pathology, the number is like plus minus this one. Really, the lecture will start, but the attendance will be taken.
It means the effective. Oh, they live together. Okay. So where is the MCO? Okay. Okay. 1, 2, 3. We are going to the official session. Can you start the session with Surah Fatiha? Can you start the recording?
All right.
Okay. Hi, students. Please, I would like to welcome all of you with the interactive clinical pharmacology session. And I think I'm getting a noise. Can you take care of microphone? Yes. Okay. So this interactive clinical pharmacology session is almost like a practical and hands-on understanding the fact you have learned over last 2 days regarding pharmacokinetics. So during the session of pharmacokinetics, we have already covered 4 major steps like drug absorption, drug distribution, metabolism, and drug elimination. So it went mostly with the theoretical basis, giving some clinical scenario and examples, and really we didn't have much opportunity for hands-on. So I believe this session is going to meet that requirement, to really visualize and enhance your understanding about the topic. So saying so, if you see here in the stomach, can you see any drug? Is just why is blue color? Because your portal venous drainage is going on, right? So drug absorption, imagine this is an oral route, right? So what happening if you're giving an oral route and absorption is very good, Can we ever achieve 100% bioavailability in oral route? Anybody?
No,
No.
cannot.
It's not possible, right? So in oral route, if a very good drug, nothing wrong with the pharmacokinetics of the drug, it is highly lipid soluble drug. It match all the criteria of drug absorption. It is low molecular weight. It has high lipid solubility. It has very small. Dissolution disintegration time is fine, but still you cannot get 100% bioavailability because of, you see, always there will be first pass metabolism, right?
Yeah.
So except intravenous route, every other route going to disturb with your rate of absorption. Am I correct? Okay.
Yeah.
So more. I cannot hear. Can you repeat? What is the question? Yeah, if any drug having more bioavailability, it is inversely proportionate with if they have more first pass effect, it is inversely proportionate with the drug bioavailability. Now, who can tell me actually what is bioavailability?
I think
The amount of drug that reaches the systemic circulation.
Okay, so after your administration through the route of administration, either it can be oral, it can be sublingual, it can be intramuscular, subcutaneous. After your site of administration, how many percentage of the drug after liver is going to this is systemic circulation. So one of the determinant factor for bioavailability is the first pass metabolism. So when you are selecting a drug, you try to get to know because same drug maybe because of different pharmaceuticals company because of their company standard, it may can vary. The same drug, same generic drug like aspirin, if you take drug from 3 different company, the first pass effect may not be same. So that's why some drugs are more expensive and some drugs are less expensive. So this is just recollection of our previous information. So here, can you prescribe insulin orally? Ever you heard insulin can be given orally?
Cannot. No.
Cannot. So why? Because if you give insulin orally, yes. So what gonna happen? Insulin, some other drugs like drug having proteolytic relationship or enzymatic destruction, you cannot give them. So some drug highly metabolize into the GIT. So even they are not absorbing. Can you see it is stopped here? Is already metabolized here, right? Faham?
Yeah.
First pass metabolism, does it only occur when you administer drug orally?
Mostly or enteral route, oral, sublingual, and some cases, not all, some cases of parectal. So enteral route mostly goes for first metabolism, but more common, more obvious for the oral route, not for other route. Why? Because first pass, you have to transport the blood to the liver through the venous circulation. So only your stomach and duodenum is innervating by your portal circulation. Some part of the anal canal also supplying by your portal venous. So wherever the organ venous drainage is portal vein and you are giving drug there, it can be oral, it can be parectal. Some cases, yes, they're going to have first pass metabolism. So after first pass metabolism, second disturbing element, it can be enzymatic destruction, isn't it? So classical example is insulin and some other drug. So some drug even can be metabolized within the GIT. So you refer back to the PowerPoint given. So if you see here, if gut metabolism is more, no absorption, isn't it? So it is also another disturbing factor for drug absorption. Now, if you want to really compare one drug, if you want to calculate the bioavailability, it should have a systematic way of calculation. How is that? The same drug you give intravenous first. After intravenous, okay, You took the example, any injection, you took the very cheapest company. Even after injection also may not be 100%, because that drug doesn't contain adequate or sufficient amount of active ingredients. So that particular drug, if you give intravenously, you can see the peak plasma concentration here, maybe 100 or 80. The same drug, if you give orally, you can see the difference, isn't it? It never can reach orally, it never can reach 100%. So this is how, always there will be a gap. Drug you're giving IV, drug you're giving orally. So always it normally 65 to 75%. So we calculate bioavailability area under the curve, or the percentage of the drug after oral administration, which is maybe 65, divided by percentage of the drug you're giving intravenously is 90 to 100 times 100, because you want to present the result in percentage. So it will be coming around 65 to 70. So so far, any confusion, any difficulty in your concept understanding bioavailability? Adeta? Okay. So after bioavailability, I would like to show you how pH really can influence your drug absorption.
Doctor,
Yeah.
so will we be tested in exams on the calculations just now, or is it just like
There will be. It will be more clear. The specific calculation will be coming tomorrow. I think I have one more, right? Tomorrow or day after tomorrow.
Oh, okay.
We have one more tutorial. So that session is all about the calculations. And if I'm not mistaken, in your mid code, there will be at least 2 calculations. It's not very difficult, just is your concept, right? Okay. Now refer back here. Drug absorption always happen. There were 2 major conditions was there. Drug should be ionized. Remember the Henderson-Hasselbalch equation was telling mostly unionized drug, if they are separated by a semi-permeable membrane or cell membrane, movement occur from unionized only can travel. Water soluble particle cannot travel. So if example, if it is an small intestine, if it is an alkaline drug, so what gonna happen? So alkaline drug or lipid soluble substances, unionized particle going to absorb. Okay, so this is the application of our what we have learned during the drug absorption criteria. Unionized lipid soluble particle better absorb into the, if they are separated by a semi-permeable membrane, and it can be proven by the Henderson-Hasselbalch equation. To do so, you have to have a very good idea about the pH of the media. So as I said, you see, I assume and I know these drugs are alkaline, so I create the alkaline pH. The pK of this drug is alkaline, and I create the media sodium hydroxide alkaline. So alkaline drug in alkaline pH better absorb. If I go reverse way, it will be opposite. Alkaline drug in acidic pH, there will be more elimination. So is there any confusion to correlate the pH, pK, and drug absorption? It's open question to all. I would like to again clarify with you, we are discussing now how to correlate pH of the media, pK of the drug, diffusion in presence of a semi-permeable membrane. Normally, they follow Henderson-Hasselbalch equation. Okay, so summary of that equation, always acidic drug in acidic pH remain unionized. Basic drug in acidic pH remain unionized, so that they will be readily absorbed. They will be easily transferred. Okay. What is the drug transport? Okay, so what is happening here? It looked bit funny, very childish, but this is a free site, so that's what we can get. What is the criteria for simple diffusion? What is the driving force?
Concentration gradient.
Concentration to low concentration.
And how long it going to continue?
Until equilibrium is achieved.
Very good. So all answer you're going to get here. So this is you are giving the drug orally, and after absorption, what will happen during absorption in stomach, concentration will be higher. So now it is telling from high concentration it moved to low concentration until when? Until both sides become equilibrated, right? So it matches the criteria you have set. So movement of substances from higher to lower concentration until you achieve the equilibrium. Let's go to active transport. What is the special two things you require for active transport?
Energy in the form of ATP.
Energy.
Yes, not only energy, you need carrier protein as well. How many which one is more common, simple diffusion or active transport?
Simple diffusion.
Yeah, you can see that simply you can see exactly this is how your pump system occurring within the body. Can you imagine the pressure here is very high pressure, this part, because of more osmolarity, right? More solution is here. So very high pressure. Here definitely pressure is low. So to run this pump, you need energy and it acts as a carrier protein. So majority time there is a one example, very classical example, chloroquine, now very famous drug during this corona time. Chloroquine, if you give, it causes hypoglycemia. And majority time, if you are giving chloroquine with infusion, you have to add glucose. Why? Because chloroquine actually absorbs with the active transport system and it consumes a lot of energy until it can cause hypoglycemia to the patient. So that's why not many drug you are finding, who really absorb by active transport. Scientists always, when they're working in the pharmacokinetic parameter, always they try to play with the fixed law rather than going by active transport, because definitely these drugs cannot sustain in the market. So whatever example is given for facilitated diffusion and active transport, it's very important because not many drugs actually adopt this transport system. The reason it requires a lot of energy. Okay. And our source of energy actually carbohydrate, protein, and lipid. So this is also another pump. It's in the same thing, they're showing in a different way. Okay. What type of drug actually after oral administration it can reach to the brain? What are the special criteria they should have? I have shown you a video.
Able to cross the blood-brain barrier?
Yeah, definitely. But what type of character?
Small molecular weight.
Very good. But first thing should be very high lipid soluble drug. You remember the video I shown, caffeine, alcohol, nicotines, right? Until spinal cord, not all CNS. So very high lipid soluble and low molecular weight drugs are the participants who can really admit to your brain. Okay. Some drug, if you this is going to be correlate a little bit with your elimination. So mostly, what type of drug actually pass through the glomerular filtrate?
What is
Free
for
drugs and water soluble.
Free and water metabolized free drug. That is the simple answer, right? For tubular reabsorption, what type of drug should be tubular, candidate for tubular reabsorption?
Lipid soluble.
It should be lipid soluble. What type of drug body forcibly eliminate through the proximal convoluted tubule?
Lipid soluble.
Yes, correct. This type of curve, if you're doing any experiment and suddenly you got the data is like this, you assigned your junior scientist to collect the sample from the animals or human body, and you can see at the beginning it was the highest concentration and followed by it reducing the concentration, and the curve shape is exactly like this. How many inferences you can make from this curve? What are the information actually giving this curve?
The half-life is always constant.
Very good. So this curve is telling, okay, firstly, it actually represents the route of drug administration. In your mind, do you have any doubt this medication is given by intravenous route?
No doubt.
Why? Because at 0 time, you can see the
max?
highest concentration. Okay. And from this curve, can you calculate the half-life of the drug? You
Yes.
see, if you started here 100 milligram, exactly you can see here 50 milligram, right? Exactly 50% drug is already gone. This curve, can you give you some other essential information about drug elimination, about patient kidney status and dosing of the drug? This type of curve follow first order kinetics or zero order kinetics?
First order.
This kind, yes, because you can see a constant fraction of the drug is eliminating with each half-life, isn't it? So good for this, you can calculate half-life, you can calculate duration of action of a drug. This part, it bit crucial. I was telling you, remember I said after second half-life, how many percentage of the drug you are eliminating?
75%.
75%. Okay. Remember this thing. This portion is called therapeutic window. We always want to be our drug concentration here. So what happened after second half-life, drug concentration is already here. This concentration does have any value within the body? After second half-life, when 75% drug metabolized, your concentration remaining here. Panta.
Yes.
It means, yeah, anybody have any doubt? What I'm saying, after second half-life, your plasma concentration below the minimum, this window we call therapeutic window. Minimum dose, which can produce effect, maximum dose until there is no toxic effect. Only this portion we call therapeutic window. So that is the ideal situation. And each drug, we already know what should be the plasma concentration. Why paracetamol 500 milligram? Because paracetamol 500 milligram always maintain this plasma concentration. It always remain within the therapeutic window level. But if you try to give paracetamol 250 milligram, it will be remain here. Drug is within the plasma, but it cannot produce any effect. If you go more than 1000 or 2000 milligram, you are at the toxic concentration. So you'll see the adverse effect, dizziness, patient may can vomit, patient may can vomit with the blood vomiting, patient may can have peptic ulcer. So these are the all toxic effect can happen. Okay. Now, what I was telling, you see with the normal clearance value in a drug, it determines which organ functionality. Clearance value?
Liver.
No.
Oh, kidney.
Very good. Clearance, it denotes the glomerular filtration rate, urine concentration, and drug dose. Somehow, 1% glomerular filtration is less, but you give the same dose of the drug. What happened? Where is
It
the
goes
drug?
into the
Toxic.
Yes, yes. So all the time, that's why before we prescribe long-time drug, antihypertensive, insulin, these are the drug patient have to take for a long time, anti-asthma drug. We always have to do renal function test. We always want to see patients' urea and creatinine value. So that will give us a picture of kidney status of a patient. Why? Because with a very ordinary dose, and if clearance value is not normal, if clearance value is higher, patient kidney is problematic, simple dose, a normal therapeutic dose, it doesn't remain in therapeutic window anymore. It reaches into the toxic concentration. So what is the alternate we have? I said there are some drug we know which is eliminating through the liver, isn't it? So we can adopt those kind of situation. Now, clearance is the the parameter for judging your kidney function. So now what happen if volume distribution is low? What will happen?
shorter half-life.
Shorter half-life, and this drug volume distribution, short half-life, one matter. Second matter is they remain only in one compartment, isn't it? But if you see here, drug become diluted, isn't it? Plasma concentration is compared to here. Okay, so go here, drug already travel to already window. Normally, ideal situation should be like this, at the midpoint. So here, if volume distribution increasing, what happened? The drug become very diluted. So that is, you will see very minimum amount of drug concentration. So redistribution occur. If redistribution occur, half-life should be increased or decreased?
Increased.
Okay. So let's go further details about the volume of distribution. This is simple, easy first. What do you mean by three compartmental model of your body regarding drug volume distribution? Why we categorize your body in three compartments? Who can explain me?
Because we have GIT, then the circulatory system, and then the body tissues.
Any more further answers? Anybody want to add something?
The interstitial fluid, the blood.
Almost there, but still not fully the answer I'm looking for. Anybody?
Yes.
Why always
Your ICF, ECF, and your vascular compartments.
ICF, ECF?
ECF and your vascular compartment.
Okay, so still you are in body fluid. Somebody want to add something? Where is the all different VD? No, I'm saying why you are dividing your body in three compartments.
Because there's not always equal distribution when you have the fluid.
So how many area actually you can distribute your drugs? That is my question. In three compartments, right? What are those compartments?
A vascular compartment,
Firstly, vascular, correct?
interstitial space,
Interstitial and intracellular, both fluid.
GIT?
And then your adipocytes and muscles.
Yes, I'm looking for that. So 3 compartment means is 42 plus, you see here. So first, if you give first fighter, it will be only covering your vascular compartment. This drug is further lipid soluble and it has moderate low plasma protein coming interstitium, right? And you see the color change is very, so plasma composition is very high. After that, it becomes little bit more lighter, so diluted. Concentration is less. But when it's a highly lipid soluble drug and it can travel to CNS, it doesn't go CNS. Upon solution of CNS, immediately it will go to your fat tissue because you chosen a drug highly lipid soluble. So must be distribution is more than 42 liter. Why I'm focusing 42 liter? Because 42 liter include only 2 compartment, your plasma compartment, extracellular, and 40 liter. If 42 plus, it actually definitely there is a matter of redistribution of the drug. So if 52 liter actually in adipose tissue, 58 liter in adipose tissue, and 42 within your first and second compartment. Do you understand with this simple explanation? With this diagram, that's why always people are telling you have 3 compartmental segments in the body in terms of drug distribution. So I think this is for your calculation. What do you say we can prove it actually? How we can prove it? Here, if you give a drug, concentration is very, very high. So you have given a drug 100 milligram and you get the plasma concentration is 20 milligram. So calculation of volume distribution, what is the amount you have given? The dose of the drug and what is the concentration you are getting within the compartment. So you give drug warfarin, after 2 hours, you know the half-life of the drug, and before half-life, you take the plasma concentration of the drug. So you'll be seeing very high concentration. So if it is 20 milligram means it's only 5 liters. So warfarin or that drug never travel more than your plasma compartment, right?
Yes.
Clear?
Yes.
Now my question, why this drug don't travel more than plasma? What a specialty they have?
Binding to protein.
Very good. Who is this?
Jana.
Okay, congratulations. It is the main factor because this drug loves to stay with the plasma protein. Very minimum amount it is releasing. And you design also like that because you want your drug to be remain in plasma having less embolism, maybe thrombosis, maybe emboli, maybe lipid cholesterol lowering drug, and also anticoagulant drug. What they will do in the brain? Normally, no, they remain within the vascular compartment. Okay, so if ECF means plasma protein binding is moderate, but lipid solubility bit higher, right? If they can go ICF again, it reduce some more plasma protein binding, but increase some more lipid solubility. So more lipid soluble they are and less plasma protein binding, their travel history will be like this. And if you choose a drug who has the extraordinary lipid solubility, anesthetic drugs, always they need to work in the CNS. So what happened? Anesthetic drug will go to the muscle and also it will deposit it into the fluid. So can you see any red color anymore? Yes or no?
No.
No. So it's the same high lipid soluble drug, 100 milligram you have given, but plasma concentration may be 0.5. So volume distribution almost becoming 1000 to 2000 liters. So very, very high. So that's how the whole volume of distribution depending on 2 factors, plasma protein binding and lipid solubility. We always try to be in the middle zone, moderate plasma protein binding, moderate lipid solubility. Then we'll be achieving our tissue penetration. ICF means intracellular within the tissue. But if you cross total 42 liter, you will be going into the muscle or adipose tissue. It means you have chosen a low plasma protein binding but very high lipid soluble drug for your treatment. Okay, same here. This is even more further explanation. So if volume distribution is very low, so all drug mana only within the blood vessels, right? Only within your artery. So if you go further, so drug going to be diluted. See, drug into the blood and extracellular fluid, blood and tissue, and it will concentrate it to other tissue. So other area become drug. The whole tissue and adipose tissue become concentrated with the drug. So in plasma, you'll get very low concentration. So volume distribution is moving towards the
Doctor, your mic is muted.
Your mic, doctor.
now you can hear me?
Yes.
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 But I didn't mute my mic because you see I'm talking.
Yes.
Okay, okay. So have you understood? If you travel from, can you hear me?
Yes.
Okay. So if you travel from this direction to here, actually slowly you are losing your protein binding, but you are enhancing lipid solubility. Again, it's all designed. It's nothing is accidental. All pharmacists, pharmacologists, scientists, they design where your drug should be. What is the purpose? Okay. So lipid soluble drug mostly we design to go and work in CNS because they have to cross blood-brain barrier. So any question about volume of distribution?
Doctor, I just want to ask, if you have a high volume distribution for the drug, does that also mean that it has a longer duration of action as well?
Must be. It can go until few weeks. Must be.
So
because it's a body become a reservoir of the drug.
So it's directly proportional then between these two factors, your VD and your duration of action. Okay,
yes, all right. 100%. Any question about volume distribution? Is there anybody who doesn't understand it? Okay, now I give a small pause. Kindly, can you circulate your attendance form? Just you recollect things slowly and please circulate your attendance form.